what we're going to do now is we're going to have a session of some HREC chair chums. And the reason we're doing this is because I think, given our theme of practical strategies of HRECs, I thought it would be useful to hear from various speakers about the challenges that they face currently and in their HREC chairing, but to have a diversity of speakers from university, public hospital, pediatric, and Lindsay McDonald from New Zealand, Kia ora, Lindsay. Because I think that Lindsay will face different challenges in New Zealand, be that as a chair of a health and disability ethics committee, be that dealing with Maori participants and meeting all those regulations. So what I've decided to do is have all four speakers, allow them the opportunity to talk for 5 to 8 minutes about I guess some of their challenges and things they want to discuss, and then we'll probably have a question and answer session at the end. But first, let me introduce the speakers. Firstly, we have from New Zealand, we have Lindsay McDonald. Lindsay Te Ata Utua McDonald. He's a lecturer in political philosophy at the University of Canterbury. He is also the chair of the New Zealand Health and Disability Ethics Committees, which is one of the statutory ethics committees in Australia. Secondly, we have Rebecca Doyle. Rebecca is the chairperson of the Queensland Children's Health, QCH, I think it's QCH, Queensland Children's Health Ethics Committee in Brisbane. Rebecca's work, of course, mainly involves pediatric applications, so I think that's very relevant. Thirdly, we have from the Australian National University, the long-standing but slightly now ex-chairperson of the ANU Ethics Committee, Professor Michael Martin. Great to have you here, Mike. And finally, you heard from David yesterday, doing a farewell to Rob Lovely, but David, as I guess the long-standing deputy chair and now the chairperson of the Royal Prince Alfred Ethics Committee, David is going to give us a view of what happens in Public Health Ethics Committee, which is certified under the NMA. So let me start with you, Lindsay, and welcome to Australia. You may wish to provide your own acknowledgement of country, etc. But let me hand over to you to, I guess, 5 to 10 minutes, or maybe 8 to 10 minutes of what you see as your challenges, how you manage those challenges, and how you add value to your work.
Fantastic, thank you. Tēnā koutou katoa, tēnā tātou katoa, ko rima tākiri taku monga, ko rakahuri taku awa, ko takitimu taku waka, ko kaitahu taku iwi, ko ini matua taku apu. No, ta tahi au ke waimakariri taku kāinga, nei, ko Lindsay Te Ata Utua McDonald taku ingoa. Kia ora everybody, so whakapapa, I am from the area of North Canterbury. My marae is situated at Tuahiwi. Am Ngā Tuahuriri, one of the 18 Papatipu Runakas of Ngāi Tahu, and I'm also, for my sins at the moment, on a few ethics committees. So I'm acting chair, and then I will become deputy chair once the new chair's in, on the National Ethics Advisory Committee that sets what effectively is the New Zealand standards, like the Australian standards, but in New Zealand they only apply to health and disability research, which I'll come back to later. I'm also co-chair of the Health Research Council Ethics Committee, which is the committee that approves committees to do the work of reviewing ethics applications against the National Ethics Advisory Committee standards. I'm co-chair of my university ethics committee, and I'm also co-chair of, at the time it was a world first, a voluntary ethics committee for community social science researchers called, at the time, the New Zealand Ethics Committee, and now it's called the Aotearoa, it's New Zealand and Māori Research Ethics Committee. I'll just also say that I'm a bit under the weather, so if I sound vaguely incoherent, please blame that, and on a good day I might be slightly less incoherent. So the challenges and what we're doing with it. listeners, I think, will all be familiar with the ever-increasing workload for ethics committees, particularly in health. In New Zealand, this has been driven by both a research system that demands more and more publications, which means for lots of research, more participants, for which ethical clearance is required. Recently, this has been exacerbated by researchers' perceptions of the opportunities of AI, big data, and biotech. Now, it does need to be said that we haven't had a great increase in explicit ethics applications to be developing AI. However, for the committees that have been dealing with them, for people who know what they're looking for, there is obviously some ethics applications starting to come through which don't mention AI, but which are clearly looking at big data to see if on a second application they want to start looking at developing an AI out of that data. One of the problems in New Zealand that you don't face in Australia is that we have a very fragmented ethics system. So as I said, only health and disability research has a national statement, and that the scope or the health and disability ethics committees, there's 4 of them that review those applications under that health and disability research, have increasingly narrowed their scopes, so that basically now if it's not a needle in somebody or the full clinical trial, it will be excluded, and then it's thrown back to university and other ethics committees that have been approved by the Health Research Council Ethics Committee. The trouble that's causing, especially where a university has created another university ethics committee in between the main university committee and the Northern Health and Disability Ethics Committee. The Health and Disability Ethics Committee, sorry, there's a lot of institutions to be talking about here, are run by the Ministry of Health, and then the other ethics committees that look at health and disability research are typically run by the universities. That interface is not great at the best of time, and if there's any communication troubles with that interface, it means researchers can find themselves being pinged backwards and forwards, and since both of those types of committees will tend to only make a judgment with the full committee, so it could be a month in between. So what I'm saying is there's some delays in that at a time when researchers don't want any delays because their promotions rely on it, and so lots of ethics committees are now starting to get howlers from research, what we call howlers from the Harry Potter idea of letters that scream at you. That all comes at a time where, as many of you might know, there is a fiscal crunch in the New Zealand Public Service, and that means there's less and less people to help with smoothing the ethics processes. And it's, as you'll all know, it's always hard to grow ethics committees and continue to have people coming onto them. We need growth and professionalisation of ethics just at a time that is where we've got rather scarce resources and ethics staff are having to do more with less. And that again creates some delays that applicants are getting frustrated by. And all this has happened as the previous government set out a major reset of the health system. That has meant we've lost a lot of health research and research governance systems we've lost them to, how could we say it, to a bit of a vortex of institutional change, and there's major losses in ethical research, institutional memory, and Māori ethics and research capability because of some of the policies that got reversed. That's all to say that we have trouble retaining Māori and Indigenous capability in research ethics. I can only imagine how hard it is in Australia after the Indigenous exclusion that was the outcome of the voice referendum. I imagine that is having ongoing effects onto the willingness of people to be part of governance for the Crown in Australia. Here, perhaps differently, those holding expertise, particularly in health, are actually now too busy because Māoridom has mobilised in Waitangi Tribunal claims and court claims. The Waitangi Tribunal is our Royal Commission for treaty breaches. And so many, particularly Mana Wahine Māori women, are incredibly busy with local and regional and centrally organised claims against the government. And that will continue, and that makes it very hard to get senior Māori onto the ethics boards at the moment. One point of difference between Australia and New Zealand is that in Aotearoa, we would expect our committees to have members with recognised awareness of tikanga Māori, te ao Māori, that is the laws of Māoridom, the overall idea of what it means to be Māori. Whereas I understand that some of your some of the national statement is not quite explicit about that, and so that you tend to have people who have researched with Indigenous peoples rather than Indigenous peoples themselves. But again, it's quite different in New Zealand, where our latest census tells us that there's 20% of 20% of the population in New Zealand is now Māori, even if it's tens younger. About a third of that's under 18. Gordon, how am I going in terms of
Okay,
time?
what I might do, Lindsay, is I might cut you off there, but let
Yep,
me just ask you a couple of quick questions. Let me
yep.
just make a point, though. Your last comment about it may be different in Australia in terms of having people that understand about Aboriginal and Torres Strait Islander research. I think we are woefully underdone in ethics committees having that expertise. I personally believe there's a need for specialized committees to provide that advice. Having one person on an ethics committee is, I don't think, enough.
Mm.
One good point that was asked, what about Maori data sovereignty, Lindsay? Because noting your comment about the lack of Maori on your committees, how do you deal with Maori and Maori data sovereignty?
So most of the time you'd see in New Zealand application forms that people would be asked to discuss Māori data sovereignty and how they were retaining it. It's a real problem in New Zealand just at the moment because we're small enough. Thank you, Joy. That we don't have our own servers. Like Microsoft servers are and most of these organizations run on Microsoft are in Australia. So it's quite hard to have Māori data sovereignty. That's an ongoing struggle. What I was pointing out here is these are all ongoing struggles, and it's quite tricky. The thing about Māori data sovereignty is that it's driven out of an organisation run by the iwi, what are called the iwi chairs, and so it's Māori led. So that with the budget cuts that are going through in government, that's not really affected, and that has its own, because iwi are institutional investors. There's at least 4 iwi that are billion-dollar enterprises now, because they're New Zealand institutional investors. They have quite a lot of sway, and data sovereignty is a real thing that they want to deal with. So there are efforts being made to ensure, and in fact, there's already a Māori startup that has got a server in New Zealand that will start to look after Māori data sovereignty. I think it's, I suppose the thing I would say is around AI and data sovereignty is that the Brennan Center in America is rightly famous for defending individual privacy against Bush's security laws. One of their lead researchers was here looking at the way the New Zealand Privacy Office worked, the Privacy Commissioner worked, and I had a chat with her, and she said, yeah, AI is turning out to be a really big problem. We've just employed someone. So even in the center of data security and privacy, the major US think tank about that thing, about that sort of issue, they'd only just 6 months ago employed someone. So I think there's no there's nobody out there except in the individual pockets who's really able to talk to these overall issues. I said okay to some of these committees on the basis that, you know, I'd be just tipping through, you know, on normal ethics issues, and all of a sudden I wake up and I have to deal with data, big data and AI. And I think it's really unfair that I ended up in this situation, because these are extraordinarily hard issues. That's fantastic, Patrice. Yeah, that is really
Yeah,
fantastic that to
yeah,
hear
it's
that you.
absolutely good to know and as I say, I mean, you know, perhaps I'm generalizing, but I feel we always have to do better, and you know, we're just some committees are good, others have less.
Yeah.
I know my own committee doesn't have any representation on it currently. Okay,
Um,
Lindsay, I'm going to move
I
on. Sorry.
I'll just add one last thing. One of the reasons that I think it's really important is that I think ethics committees are about building trust with the community over science, and in that way, they can be a tremendous source of reconciliation between Indigenous peoples and settler state. And so I think I'm quite passionate about that particular idea within ethics committees, because that's what they're there to do.
Thank you. Okay, now Rebecca, I'm going to hand over to you to from a pediatric chairperson, tell us about the challenges you face and I guess how you're managing them and other things you might want to discuss.
Thanks, Gordon. Hi, everyone. Thanks, Lindsay. I agree with Gordon. I think New Zealand does a far better job than we do with their First Nations people. So that was really great to hear. So thanks for the invitation today. My name is Beck Doyle and I'm the acting HREC chair at Children's Health Queensland and have been doing that for about 14 months. I've been on their committee for 8 years. My day job is nurse researcher here and my clinical background is in paediatric intensive care nursing. So when Gordon asked me to think about some challenges that we face as HRECs, I think at first I thought, how are we going to narrow it down? It feels like applications are becoming more complicated and the weight of responsibility on HRECs feels heavier. Some of those challenges are unique to children and some are not unique to paediatrics, but I guess they have that extra layer of complexity because someone's consenting for the participants in all of our cases. Projects are becoming more challenging to review because they're more complicated in project design. They're becoming more logistically difficult to deliver the trial and they're carrying more risk, and we're seeing that more and more, but we're cognizant at the same time that with that increased risk is an increased potential for benefit, and sometimes that's life-changing for participants. But I'm not quite sure that we're keeping up with the changes to the level of complexity. For us as a HREC, the level of risk is becoming more challenging to ascertain. So what we think is an appropriate risk on a HREC may not be in sync with what the parents of a profoundly disabled child who's got a life-limiting illness thinks is a risk. Some of those children have terrible prognosis and really poor quality of life, and those parents will roll the dice on, or some of them will roll the dice on anything, and the trial is a Hail Mary to buy their child another few years or improve their quality of life. So it's really hard for us as a HREC, I think, to get that balance. And I'm still not sure what the right answer is. Do we give the parents all the information and leave it to them to make the choice, or is it outside of their parental zone of discretion and they need to, because they can't be objective and the risks need to be weighed up by the appropriate qualified people. So as those risks increase, I guess we need to be confident that we're reviewing projects adequately by the appropriate people, and that's becoming more and more challenging. I love that we can have a robust discussion around the table as an ethics committee, and often there is no right or wrong answer, that people are bringing their opinions to it. But sometimes we really need to rely on experts to break down those ethical considerations scientifically and methodically. And so I'm not quite sure how to do that best, whether we rely on other HRECs, which we sometimes do. We consult other HRECs on what they think of a de-identified case. Do we bring in expert advisors? Do we use the clinical advice of the people on the HREC, which varies? Sometimes at a meeting there is the perfect storm, and the people that are best to deal with that project are in surgery, or they're on leave, or they can't make the meeting. Do we ask the participants or the parents of those participants that are unique to that cohort what they think, or is it too specific? Would we have to ask too many specific cohorts, and would their opinions vary between each other, or is it a bit of all of the above? So I do feel like sometimes we're grappling in the dark a little bit there to try to make the best decision based on the best scientific evidence. Another issue that's coming up for us, which probably is unique to children, is the use of biological samples that have been stored for future research, and the parent or guardian has consented to that use, but then the child turns 18. So Emma's presentation yesterday on dynamic consent felt very timely, and we currently don't have a clear procedure in place for what to do to manage this. They probably should, those children should probably have the opportunity to reconsent once they turn 18. Often they don't know that those samples exist. And so is it the parents' responsibility to explain to their child that the sample was used and why it was taken and why they provided consent? I don't think it's the researcher's responsibility to cold call a young person and say, hey, we have your samples here. And those conversations can be really difficult for families and for parents, especially if the child was critically ill or had a disease with a really poor prognosis, and they've since recovered. And sometimes the parents haven't told them the full extent of their illness or actually how sick they were. So that's certainly one that's cropping up for us, among other things that I'm sure we'll come up with others. And another one that sticks out is the assent versus consent debate for us, which varies from state to state, and consent or assent in research varies to assent for clinical procedures. So that one often generates a lot of discussion for us as well.
Oh, that's wonderful, Beck, and some really really complicated things there. Yeah, I mean, and the role of HREC versus the role of parents, and of course, ethics committees can try and stand in the shoes of the participant. But I think, as we've heard yesterday from Penelope and Brian about those ME trials, unless you actually go to your Facebook group with that community of practice, with that advocacy, will you ever actually know whether or not the participants or the parents thereof want it? And sometimes I think ethics committees can get a bit caught up in, well, we wouldn't do it, but then if you don't have that lived experience, how are you ever going to make that decision? Question, assent, consent. 4.2.7, 4.2.8 of the national statement says, 4.2.8 says you don't have to get parental consent sometimes, but you're talking about pediatric cases where the children are, clearly not capable of providing consent. So what are the issues that you face then, if really?
So for us, we do grant assent in some circumstances, especially in youth justice studies, and studies where it would be detrimental to the child to ask the parents for the child to consent. They may be disclosing information they don't want to disclose to the child. So we do grant it, but as a rule, we would say to researchers who often will submit those assent forms, we would say they still need parental consent. We love that they would be providing evidence that they've had a discussion with the child or young person, and we would always recommend that if that child or young person is saying, I don't want to be a part of this, that the parents would respect their wishes and not provide the consent. So we don't want to be in a situation where the child is saying no, but the parent provides consent. It's tricky in Queensland because there's no written legislation to say that a child can consent for themselves to be a part of research. But there's nothing saying that they can. There's literally nothing written. There is about clinical procedures, but not about research. So then you get in this ridiculous situation where you may have a 16-year-old who has a baby who is capable of consenting for her baby to be in a trial, but can't consent for herself to be in a trial. So it's really, really tough to navigate that legislation and do the right thing there.
Yeah, and I guess you would continually have to weigh up the a balance of Gaelic competency and Marion's case, and sometimes you can't, and you probably have to seek other advice. And that's wonderful, Rebecca. Thanks a lot for that. Some great examples there. I'm going to move now to Michael. Michael is the longtime chair of Australian National University, HREC. The universities, of course, will have different challenges. Some resource, some because of the breadth of applications you get. But Michael, I'm fairly sure you'll give us a fairly good précis of what you have faced in your time as chairperson and how you can hand the baton on and improve what happens.
Oh, for sure. And thanks, Gordon, for inviting me. I'm coming from the traditional lands of the Ngunnawal and Ngambri people and pay respects to elders, past, present, and emerging. Yeah, look, I was the chair of the ANU HREC for nearly 10 years, and they say you don't get as long for murder. So, recently paroled. So a lot of things have come across my desk, some of which would curl my hair if it were long enough. But here are a few that sort of have stood out over time. The first one is something that I've heard so many times from researchers, which is basically stay in your lane. And the word overreach is one that I hear an awful lot. And, I'm a tall guy, so I do have a big reach, but, I reach as far as the national statement says. I don't go further. And yet I'm constantly told that I do. And so this breaks down into several bits. There's the part of the national statement that talks about research merit and integrity. And yet researchers consistently tell me that I'm not supposed to consider the merit of the research. That's already been done by some granting body or their supervisor in many cases. To which my response is always, yeah, but what about beneficence? Merit, which speaks to benefit potentially, has to balance off against risk, and beneficence is a core principle. And so if I'm not allowed to consider one part of that balancing act, how on earth can I consider all of the parts reasonably? We already get told so many times by people that we worry too much about risk, but if we're told we're not really allowed to talk about merit, then what else is there for us? I'm similarly also told very often that methodology is off limits. Even if it's a 100-year-old methodology that hasn't been changed because it's been passed down from supervisor to student to student to student, when better things might work more appropriately. And my response to that has always been, well, if I've got expertise on the HREC that tells me you can't achieve your research goals, then I'd better get involved, because not achieving your research goals but still impacting people potentially negatively is an issue. So yeah, being told to keep my hands off stuff, well, it's red rag to a bull, of course, because it just makes me want to go hands on. But at the same time, it's something that happens a lot of the time at universities. And this is because we live in our towers of Babel, and people like to say, well, your tower is over in the research ethics and integrity area, so stay away from my tower. And ANU, as you probably have read in the newspapers, invests a lot in building towers, perhaps too much money. Huh? Anyway, we won't get political. Another issue that comes up fairly regularly is one I would refer to as researcher expedience, the idea that if they can go around us, they will. So a prime example of that was a researcher who had a really interesting research project that had a component that definitely impacts Indigenous peoples. And so we went back to them and said, look, well, you've got to go with some consultation and engagement here, because without that, you're working on them, not with them. And their response was pretty simple. Their response was, well, we don't have very much time to do this research, so we don't have time for consultation and engagement. And I said, well, you have to make time, right? And their response was to remove that component of the research. But we said, oh, you know what? You have to do the consultation and engagement anyway. Read page 6 of the IATSIS code. If it impacts Indigenous people, it is Indigenous research. And so you can't just go around us. The upshot of that was fascinating. The upshot was we were then accused of negatively impacting the mental health of the PhD student involved. And, I totally get that the student was distressed because it put their candidacy behind. But at the same time, if your candidacy relies on doing research, it ought to rely on doing the research properly. And cutting corners is not the way to do that. So we always tell researchers plan ahead. They never listen, sadly, which sounds like a burn on researchers, and it isn't really. I love researchers, but researchers need to go we need to go around the corners, not cut them. Two very quick last things, Gordon, because I know time is of the essence.
All good. No, it's fascinating, Michael. Just keep going.
All right. Well, the next one is the question I get a lot. I got an awful lot, which is, you haven't approved this one thing I'm planning to do, but it was approved 4 years ago for another researcher who, and he and I have got together, or she and I have got together, and you're very inconsistent. And my response to that was, well, we're not like the criminal law. We don't run on a system of precedent. We run on a system of what works now. And a prime example is gender norms. We had someone trying to replicate a study, and they wanted to know about the gender of the individuals involved, but they only asked about males and females. And I said, well, you need to add options for people who don't identify as male or female. And this is a respect thing. It falls under respect for persons. If you exclude them, if you other them, then you're harming them. The pushback was insane. I was told, well, this will cause my study to be unpublishable because the study against which I'm comparing, which was carried out in the 1980s, only included male or female. So I said, well, okay, that's fine. You can ask the question you want to ask if you pitch it correctly, but you also have to ask a question that does not other them. So what ended up happening was they asked for something more clinical, which is sex at birth, which is male or female in the United States, which is where the study was being conducted. But they also had to ask a question that allowed them to not other the people involved. I think the outcome of that was the research went ahead and I earned an enemy. But, friends are forever, enemies are ephemeral, as we all know. Or maybe not in the post-truth world, but who knows? But very finally, and this is a bit of a bugbear, and it's once one has gone through the exit door from being an HREC chair, one can think about all the problems that one could solve if one was still there. And that's the question of this is a big ticket question, Gordon, that I think I'd love your feedback on, and the feedback of others around. The role of ethics committees, certainly universities, seems to be a hurdle role. We're there to approve research so that the researchers can get on with it. And then we disappear. And there's no real oversight post approval, because it's not resourced. I mean, we never look at anything post approval, apart from essentially self-reporting by the researchers. They fill out annual reports, of course. And so if a problem occurs and they tell us about it, we know about it. But of course, if they don't tell us about it, we never do. And we can't ever chase them down because we would need, more people in order to do that. And so here's my bugbear around this, which I think is worth everybody thinking about. And that is ethics a compliance thing, or is it an integral part of the fabric of research? Now, I think very much it's the latter. And if it is the latter, then we need to think about it rather differently. And so instead of research ethics committees being your enemy, your adversary in a process of, there's got to be a winner and there's got to be a loser, maybe we should be thought more carefully around the idea of just being a broader part of the peer review process, right? Where, we can add value to research by making suggestions. We can add value to research by allowing for people not to fall into the big holes that they've dug, because we can see what those holes are, and so on. And then for us to be engaged later. This happens informally. I've had feedback from researchers where they've said, oh, you really improved my research. And I love getting that feedback. Equally, you never hear back from a lot of people, particularly the ones who regarded you as their enemy, because, there's a bitterness that doesn't ever resolve. As I say, I think I left the ANU with my picture up on more dartboards than I can ever imagine. And I'm still at ANU, of course. So, yeah, we'll see if my picture changes. So anyway,
Funny
that's
stuff, Michael. So I mean, a couple of things. I think that yesterday in the quality assessment of ethics review session, Holly Fernandez Lynch was talking about the work of the American advancing the effectiveness on research oversight of ethics committees, and that. And I think I was talking about it sort of myself. It's very hard to tell what the quality outcome is, because what you really have to do is improve the quality inputs. And so, the annual reports that come from researchers, I don't know about anyone else on this line, but yeah, look, wonderful. Tell me when something goes wrong. Apart from that, good for you. The final reports, I like seeing final reports and the outcomes from them. But how do I know we've done a good job? Yeah, not sure, unless we are, unless there's an assessment of our effectiveness. Which, this is one question for you then. In terms of proportionality, do you feel that ethics committees sometimes have a disproportionate influence? Where is that line between essential versus nice to have, and how do you navigate that one?
It's a tough one, and the lack of oversight. So I have this theory, and the theory is that we spend a lot of time making sure that something like an information sheet is as good as it can be. But I have this idea that maybe information sheets never even ever get printed, and no one ever sees them in some cases, right? Not, obviously, if you're in a clinical trial, it's part of the palaver. But I often wonder whether the researchers end up doing what we've approved them to do. And we never find out because we never ask. And we live in this don't ask, don't tell environment, which is unfortunately corrosive to inquiry. I just wish we were all seen as being in the same, well, I was going to say all in the same boat. We're not in the same boat, of course, we're in different boats, but we're all in the same storm. And so we all need to navigate what the storm produces. And if researchers could see us as a vehicle to partnership in research, right, then it would be a lot healthier, I think. Now, I probably haven't answered your question there, Gordon.
Well, that's okay. Lindsay wants to make a comment on this one. So Lindsay, fire away, and then we'll get on to David.
Yeah.
Oh, sorry, I don't. I was just going to say that I think there's two things that I think about. The one where you've got people, sending you howlers and yelling at you. One of them is that I think research ethics review is in a really funny place for most researchers, in that it's the first time that they drop from their abstract ideas, particularly in social science, and medical science as well. They won't have actually written about real people. They will have written about groups of people. So they haven't actually had to imagine where they're going to stand to hand out the survey, or how they're going to ask for consent. And researchers being research, they're not generally the most social of people. They'll be salespeople if they're the kind of people that could easily ask others to help them, right? So they've got to go and ask for help from the public. And I think some of that anxiety gets pushed on to review committees a lot of the time. One of the ways that I ameliorate it at Canterbury, where I'm co-chair, is I spend an awful lot of time with the postgrads. I go right around all the postgrad inductions for all of the departments as much as I can, and that changes things quite a bit. And I talk about research ethics as a conversation rather than a gatekeeping exercise. But I think I'm lucky because there's not as much pressure on us here to be research governors, where we can actually focus on research ethics. And I think from my work on the voluntary committee, that changes the dynamic. If you're clearly there to do the research ethics rather than to watch for liabilities for the university, and I think it's probably incumbent on us, this is just a personal opinion, to actually push back quite heavily against the universities wanting to run their research governance through human ethics committees. They need to start amping up their own efforts and not tag research governance on top of us around things like data. Yeah.
Thanks a lot, Lindsay. No, Michael, that's a really wonderful introduction, and I really loved your point about that we go on what the norms are now, not what the norms were 5 years ago, because things change and societal expectations change and evidence changes. So we can't necessarily base our decision on what happened N years ago. But some great questions, and now we're going to move to David. David, as the current chair of the Royal Prince Alfred Ethics Committee, you as a chair of a NMA certified and ethics committee and HMRC accredited will have different challenges from the others. Please enlighten us as to what these are.
Well, I guess I should probably start out with some pick up from where Michael was talking, and I think one of the pleasant things about working in a large local health district ethics committee is that most of our constituency are basically friendly. They understand ethics is important. They know that there's such a thing as the Declaration of Helsinki, and know it's very naughty to say nasty things about it. So they're actually really very friendly. But it doesn't make life easy for either us or them. And there are a number of reasons for that. I think the first reason is that, once again, it's possibly unfortunate that HRECs end up being the place where a whole string of other checklists get checked off. Nick Zepps, in his struggle to separate governance from ethics some decades ago, tried to get rid of that, but of course it's crept back in, and so now all kinds of things which are not necessarily ethical are being looked at by ethics committees. They're things like, is the protocol in a reasonable format? Is it consistent with ICH GCP? Is it consistent with ISO 14155? Does it follow Spirit guidelines? A whole string of things which don't actually have necessarily any impact on the ethics, but have a huge impact on whether, in fact, they're acceptable to various bodies that may want to publish research or accept the research. And under the National Mutual Acceptance Scheme, there's no way to look at that apart from the original HREC. The next issue, which occupies certainly a lot of my mind, a lot of the mind of time of my colleagues, is the issue of how do you actually engage with CALD populations. In our world of 40-page, 50-page patient information sheets, there is no easy, unless everything is translated for every language in our community, and we know it certainly isn't, how do we actually engage all these people? Now, what CTIQ is undertaking a very bold initiative to try and cut out a lot of the extraneous information by exiling it to appendices or web links and things. But it's extremely hard to persuade companies to agree to that. And of course, if you look at the GCP guidelines, which once again the government insists upon us following, while the national statement may have 10 dot points you have to cover in information sheets, ICH GCP has about 23. ISO 14155 has over 40, and it covers 3 pages. So it's not surprising you end up with 40-page information sheets. And I think, once again, as Michael has said, it's entirely likely that these information sheets end up in the bin. Despite the requirements, the researchers sit down carefully with the participant, go through it and explain it all, take notes about it. The fact is they almost certainly end up in the bin. And so I think it's an important issue, how we actually reduce the amount of content we're stuffing into people's eyes and ears. And it's not something an individual HREC can take on, but it does actually need broad support so that we make sure that we provide a system which is flexible enough to give the people who want to know a little bit, the little bit they really want, and the people who want to get down to the guts of the protocol can get what they want, and it's all efficient and not too problematic. I guess the next point I wanted to make, and it's once again it's related to all of this. Huge amount of our work is involved with dealing with complaints. Most complaints are not about safety. They're about things like, I turned up and somebody tried to charge my Medicare card. Or I turned up and I got this thing which looked a bit yellow and I wasn't quite sure what it was. In some cases, they're simple misunderstandings. In some cases, they're things which people had, it was a failure to explain how the system actually worked. The fact the trial had actually been run out of a clinic, and they hadn't identified to the participants that the clinic would not charge people in the trial for their Medicare cards, but the clinic staff didn't actually ask with people coming into the study whether they're in the study or not. So they just simply asked for a Medicare card as a matter of course. And so there are lots of little things requiring a bit of fine tuning, and you often don't learn about those until people start complaining. And while they're minor, they're not safety issues. They do generate lots of unhappiness. They waste lots of time for risk committees, for participants, and for investigators. And so we're very, very keen to find a way in which we can actually discover these things quickly and eliminate them quickly before they escalate into complaints. That's probably enough from me, Gordon.
Oh, thanks so much, David. I think that you raised some really general points. Look, maybe what I'll do is the first thing we'll do, of course, is point out that no ethics committee should be dealing with governance. Ultimately, we have a role under the national statement to look at merit and integrity, justice, beneficent respect. Clearly, we have other aspects now, as we know, to ensure that research applications have involved the right consumer engagement. Arguably, and maybe this is a question we'll raise, we should be engaging better with researchers, but governance, that's really not our bag. And the conflation of the two has definitely stifled the effectiveness of ethics committees. So just wanted to point that out, and that every ethics committee should be taking that on board, that really this is about essential ethics things, not governance things. That's that's for the hospital governance office or the university governance office or whatever. So I think what I've got is a few questions just for the group in general, and maybe just in terms of something that Michael raised. And actually, no, I'll ask Rebecca first. Rebecca, David just mentioned about information sheets. So you're in a pediatric setting, you're looking at an information sheet going, oh, this is just not going to work. What can you do about this? Because in 2009 or 8, the NHMRC provided all of these information sheets, and quite frankly, the gobbledygook. I don't know about anyone online. I'd probably read 2 pages of an information sheet, probably nothing more. How do you deal with this in a pediatric setting, Rebecca?
So we're doing a couple of things. I still don't think we're doing enough. We, for the huge information sheets that really are probably a lot of butt covering rather than giving participants information, we ask them to provide a short summary that summarises the information sheet, so the parents can still get that bundle of information, but there's something that summarises it that they can understand. We ask researchers to try to aim for a year 8 or 9 reading level, which I think is probably still too high, and we're really encouraging them to think outside the box of other ways to explain their research. So infographics, videos, short little QR codes that parents can scan and listen to a 3-minute video that explains the project. We know that as a large public tertiary hospital, almost half of our parents' guardians can't read above a year 7 reading level. So it's not just health literacy, it's literacy as well. And we will push back any application that includes can't speak English as their exclusion criteria, and say find a way to do it, or build money for an interpreter into your project, because it's unethical to exclude people because they can't read a 40-page participant information document.
And okay, for the whole panel, I mean, would you agree that if the researcher had demonstrated to you that it had sufficiently engaged with advocacy group, consumers, etc., would there be any need for the ethics committee to actually intervene in an information sheet and or consent form? Michael, what do you think?
Well, we always intervene, and the reason we always intervene is because the national statement says certain things have to be there, and sometimes they're just not, even if there's been consultation. Now, that intervention can be hard or soft, right? And I have sometimes favoured the soft intervention. For instance, we've had information sheets that have been in the form of a video, where the researcher basically speaks to the people. You know, we've seen the video and this is what the researcher intends to say to people. We've also tried to work out how to create information sheets with pictures for kids. And so, you know, we're very happy to work with researchers to try to get the information that's necessary across. You know, the hard thing, like at ANU, we have to have a privacy notice. If we don't, we're in breach of the Privacy Act because we're a Commonwealth institution. And researchers go, well, no one's going to read the privacy notice. I'm like, well, but it has to be there, you know. And so we sort of have to walk a fine line sometimes, because the last thing you want to be is in breach of the Privacy Act, right, these days.
Yeah, good. Lindsay, what are your thoughts on this consumer engagement in relation to the information that's eventually going to be provided to your participants?
We have a fairly standardized set of requirements in New Zealand, partly because of things like Privacy Act, but I'm still trying to get my head around the health and disability information sheet and why it looks the way it does. We certainly, in the committees I've been involved in, we've had infographics, we've had information sheets on video, the whole 9 yards. I think there is still something, how could I say this? There's still a trust building exercise going on between the committee and the researcher to understand whether or not the researcher has properly consulted and combined that consultation with the kind of things that we would expect. This really, the metal hits the road, however you say that expression, when we've got researchers going on to Marae Māori meeting houses and they're working with the whole community. But how do we know who's going to give permission there? And that's a conversation to unpack if the researcher actually understands who the elders are that they should be working with. So as many different ways as possible, but it's true that our health documentation is still massively long and, in my view, kind of overcomplicated because we're doing research governance, not research ethics in that area.
Glad to hear we're not any different from yourselves there, Lindsay. David, you have your hand up. Please feel free to chime in.
Yes, so I'd just like to come back to this issue of community engagement. In a world where we are obliged to actually engage with and include people from non-English speaking communities, and in a world where we know that the majority of our current clinical trial participants or trial study participants are well off, well educated, well connected within the system, it's not enough to actually for a fairly well-off ethics community sit around and say, oh, this information looks pretty good. You actually have to go out and actually talk to the relevant communities, make sure the level of information is at the right level and it says the right things. A thing you could get away with telling a person from University of Sydney or ANU has nothing to do with a poor Arabic or Nepali family who migrated to Australia 2 years ago.
And I think the national statement is very clear on the fact that cultural considerations must be taken into account, and especially for studies conducted overseas. But I think the same pertains to those conducted in Australia. That unless you are doing the full consumer engagement, then you haven't done the appropriate job.
Yeah.
Which I guess is quite a good segue to my next question, which and so thank you, Sonia. Sonia sort of raised this to some extent. How do you feel about the fact that the ethics committee is a committee of last resort for something that really should be a journey, and that engagement is something that starts at the outset of the research project, not just at the point where we meet on a Thursday afternoon and go, for goodness sake, the quality of this application is rubbish. How on earth do they plan to do this? So realistically, are we, should there be intervention at an earlier stage? How can this best be facilitated both in Australia and New Zealand? And I guess, David, I'll just start with you since you're, I can see your mug on the camera. What do you think?
Sorry, I was away with the birdies, Gordon. What?
Okay, David, ethics committees are currently, I'm asking the question, are they the committees of last resort for things that should have been done a lot earlier in the piece? If so, how do we better manage that engagement at an earlier
That's an
stage?
extraordinarily good point. They're also the committee of last resort for the things that nobody wants to think about. And so actually getting to researchers and persuading them that they actually do need to think about what goes into the protocol, how they actually going to recruit people. Do they have to worry about the TGA advertising guidelines? Do they need to engage with the local communities to make sure that their information sheets are in decent shape? And could they possibly visit the diversity hub to engage with some multilingual healthcare workers is enormously helpful. But it's also the, and so we do this at Sydney LHD, and I think it's helped us an awful lot. That's why we don't have stand-up rows with our constituency anymore, because we have them early on.
That's fun. Yeah.
On the other hand, all the hot topics in New South Wales, things like taking blood without permission and then doing it with research without proper permission, issues around clinical trials on people who can't consent, end up being pushed onto the ethics committee, and they sit there because the legal system doesn't actually allow us to resolve them. And so not only is it the place of last resort, it's the place where all the hard things go. I'll give you a concrete example. There's I'll say it's a really nice study on people undergoing extracorporeal membrane oxidation, a highly invasive cardiovascular procedure for people whose hearts and lungs can't look after themselves. And what the study is just taking a bit of blood, and this machine has to have its tubing changed every day or so. And when they change it, there's always blood lying around the tube, so there's plenty of blood. It's not having any impact on the actual participant. But under New South Wales legislation, unless the patient actually agrees in writing that blood can be used in research, or the highly distraught relatives agree within 72 hours that it can be used in research, it has to be thrown out. So we can't actually do quality control research to find out which patients benefit from this highly expensive and invasive and rather alarming intervention.
Thank you, David. I think I've been thinking back to the legislation in New South Wales. Yeah, when it's not a clinical trial, then they don't make decisions on it, and then you have to. And you're absolutely right. Can any ethics committee be sufficiently constituted to be able to deal with all of these things where there should be external jurisdictions that manage that? Michael, back to my question about should we be intervening at an earlier stage rather than being the place where things come to die? What do you think?
Look, yes, we should be. And again, this is something that we're not resourced to do, but I tried to do as much as I possibly could, which would be to encourage researchers to come and talk to me before they submitted anything, because you can head an awful lot off at the pass without having to go there in the ultimate submission. Save an awful lot of time. Now, this has to be set against a tendency for the HREC to become de facto research supervisors, because look, this is the dirty little secret of higher education, is that research supervision is an essentially unrewarded activity, right? You get promoted by publishing papers. That's it. You don't get rewarded for supervising students. And so it gets pushed to the bottom of the pile a bit. And so we have seen a research supervision taking a back seat to the idea of publish or perish. Now, the HREC can't be a set of de facto supervisors, but to the extent that we can resource the HREC to be part of the research process in general, I think we can help. So yeah, I had lots of meetings with researchers who hadn't submitted, and I can't think of a case where that turned out badly, to be honest. The bad stuff happens when the first time you see it is the first time you encounter the dark corridors that research is going to walk you down. If you know the dark corridors are there and you can put some light on them earlier than later, you're much better off. So.
Yeah, and just to give you one example, Michael, even the other day, an application came to our committee last week or 2 weeks ago, whatever it was, and it wasn't research. I mean, they tried to make a silk purse out of a sow's ear, and when we pointed out, this actually isn't the research bit yet. So how about you withdraw that, and we'll give you some advice on the ethical considerations with what you're proposing to do. You go away and do that, and then come back to us when you've actually got the research ready to go. And I think what I'm pointing out there is, had there been that engagement at an early stage, they wouldn't have spent that time doing the ethics application because they felt they had to, as opposed to understood, who they could get to talk to about it in the first place.
It's absolutely right. I mean, the worst case analysis, of course, is that you end up with a phone call from the professor of sow's ears who declares to you that there is absolutely nothing better than a sow's ear, and how dare you try to turn it into a silk purse.
Yeah. Yes, indeed. Yes, indeed. Okay. Now, before I move on to questions, Rebecca or Lindsay, would you care to comment on how we better better use ethics committees to make to get where we need to go?
Really?
Yes, Lindsay, fire away.
Are you sure? Rebecca, do you want to go first?
No, you're right, Lindsay. You go first.
Okay. So I've just popped a comment in. Increasingly, I've found that researchers are expecting us to be a research ethics consultancy, which is really odd because obviously there's more and more ethics publications or publications about research ethics in most of the disciplines that need it. I was just thinking before, we're actually quite new institutions. Post World War II, New Zealand didn't really start them until I think sort of 1980s in social science. So 1986 was the Royal Commission that led to the creation of the Health and Disability Ethics. So that's quite new. So there will be institutional issues. I know Auckland does pre-ethics. It has faculty advisors, and I think that helps a lot. But I also know that Auckland's got so many applications that in some committees it's dealing with 100 in one go, which isn't really ethics review to me. So I think there are lots of ways that it could be improved. Some of the universities around Australia, I think, is it Griffiths, has a compulsory ethics program run online, pretty simple, pretty straightforward, but at least it gets people there. And I totally agree with the commenters that sometimes supervision is lacking. I'd also say that oftentimes students will do it without the researcher. We had one tremendous one where he wanted to record people who were gay, their voice, without asking for their consent, and then play it to see if people could pick up that they were gay. It was the most horrific research. And we went back to the department saying, what on earth? I was going to say something worse than that. What on earth? And they said, we don't know about it. Don't blame us. And it's a reminder that students will just go off and do their own thing. And I'd often get really annoyed at supervisors in my first term as chair, only to find the supervisor hadn't seen it and the student had forged the supervisor's signature. So it takes all sorts to make a community, and we certainly get them.
Yeah. Okay, Rebecca, over to you for the comment on this one, and then we'll move to our last question.
I think I agree. We don't have time to do all that we want to do. We're trying to ramp up our training and education internally and externally and the training really does go hard on we're not a tick box. We're not another hoop to jump through. This is why we have to protect our participants, and we use those, horrendous historical examples of why we have to, and that we're also there to protect the researchers to an extent, to make sure that they're doing the right thing. And we see protocols that come through especially from clinician researchers that are doing a project on top of their clinical load. They're novices in research. They put something in, we review it and go, no one's actually going to get hurt as part of this project, but the protocol's rubbish and they're never going to be able to publish it. So we try to meet with them before it hits the committee and say, let's try to work out how we can strengthen your protocol and your questions, because it will be easier for you to publish this down the track and your research will be better. And they're usually really open to it. And we've started post HREC meeting, if there's a lot of response to queries or a lot of concerns from the committee, we'll meet with the researcher rather than having 50 emails back and forth about, can you change this, could you consider this? So and they come in all nervous, what's the HREC going to say about our project? But once those reasons are put into context and we can hear what they were thinking when they were writing it, it really streamlines it and everyone understands what we want to achieve at the end, and it works a lot better.
Thanks so much, Beck. Okay, now I said we're going to go to 1:15. We've got 6 minutes. So what I'm going to do is ask the last question and give you a minute each to come up with an answer. So don't be surprised if it's a big question like, what could we do in Australia now, if you had the resources, to make ethics review more transformational? What are the biggest things you could do, the biggest bang for buck you could do in the shortest time to make ethics review the way you'd like it? And Michael, I'm going to start with you because you're good at thinking off the top of your head.
All right. Well, off the top of my head, the simplest thing we could do would be to have the opportunity for researchers to come and talk to the ethics committee for each protocol. The process of formal submissions through it makes it look too much like applying for grant money, right? What we need is for it to become more of a conversation. So every single time we've had a troublesome protocol for which we've run into problems, we very often invited the researchers to come and talk with the committee. That's always resolved matters, always, right? So if you could resource it, I would have every single ethics submission be not an interview, but a conversation.
Yeah, no, absolutely. And I think it just shows the difference between the written word and the spoken word. And so often that misinterpretation, not because of lack of information by an ethics committee can, lead to excessive delay. So I really, really support that one. David, yourself, what would you do to improve things?
Well, I was just typing that at Sydney HG, both ethics committees, Concord and PA, do encourage investigators to contact the committee before submitting. And there's even discussion about exactly when it should be submitted, things like that, detailed things like that. And the chairs regularly run up by people asking questions. So I think we talk to people okay. There are two things I'd really like to resolve. One is, well, apart from the issue about this length of information consent sheets, which I think is wasting a lot of time for everybody.
Thank you for mentioning that. I was going to sum up with that one, but thanks for that.
I think actually re-establishing the difference between research and quality assurance. A lot of stuff goes through these committees, and there's no way in the world in which it's really research. It may have been funded by the MRFF, and it might be described as a research project, but it's quality assurance. And the reason it's in front of the Ethics Committee is because people are too scared to say it's quality assurance, and so they want these committees to say it's okay. And it actually creates all kinds of legal problems. It creates all kinds of regulatory problems. You know, it has to go under GCP and all kinds of stuff. And you can do things in New South Wales as quality assurance, which you can't do in a research project. So it actually prevents things from being done. So if we could solve that problem, it'd be an enormous step forward.
Thank you, David. Rebecca.
Mine would probably be a little more straightforward. It would be money. I would love to be able to pay our ethics committee members. It's so hard to keep that balance of members on the committee when they're doing it in a volunteer capacity, usually over and above their full-time positions, and sometimes we're just struggling to reach a quorum or struggling to have enough people on the committee that are experts in that field. I know that the standard now is to pay consumers, but we don't feel like it's fair to pay consumers when you can't pay other volunteer members, like people who have retired but are still on ethics committees because they're doing it, you know, purely from an altruistic point of view. So I'd love to be able to give them something. I think it would make them more accountable, and I think it would at least compensate them for their time. We rely on the burden's really high, and they're volunteers.
Thanks, Rebecca, and I would absolutely second the professionalization of ethics committees, including the payment of chairpersons and non-employed members. I mean, I think that we cannot expect people to be doing this work for nothing. We've moved past that, and we just we have to be able to have accountability. So thanks for that. And finally, Lindsay, you talked about the fact you've only got 4 health and disability ethics committees. One of my questions to you was, do we need more? Especially when you just said, oh, well, Auckland University is an independent one. It has 100 applications. I cannot fathom doing 100 applications, by the way, in one sitting. Anyway, Lindsay, what are your thoughts about how to move forward, taking New Zealand into perspective?
Yeah, resourcing is definitely a massive issue, and most of our research ethics committees are managed through the research office in universities, which puts them in a conflict of interest on timelines. But my major thing would be that all ethics applications and the responses are published online to make them all completely transparent. I mean, there would obviously be some that would have to be confidential, but I think the lack of transparency is affecting both the way in which the researchers deal with it and helps them forget that usually they're being paid to research by taxpayers, and quite often they're getting a degree out of it, and they should be reminded about that. And it would put the ethics committees on notice to be more polite in their communications. We have the same issues around QA and QI, but actually it's the other way around. People want to put them through ethics committees so they can publish the QI results. And we're having some really interesting discussions with the New Zealand Medical Journal, because they are really insistent that anything people want to publish needs to go through ethics first. So they are pushing for QA to go into research ethics committees.
Okay. Well,
yeah. Well, I mean, most of it does, but it's a much smaller country with necessarily smaller and getting smaller health systems. So I'll just say I'd really like to see everything online and published, so that
I love that.
Yeah.
Well, look, gosh, everyone, we could of course go for another 3 days just on this topic alone, but time precludes us. Let me just summarize that last.